you could just ask, chat in, Rana can help you. I have no financial arrangement related to this, so nothing to disclose. So for the remainder of the hour, I'm going to go through and discuss the stages of change and the spirit of motivational interviewing, and be able to identify the core concept of what is the stages of change, or what's called the trans-theoretical model of change, and those specific components within that model, so that you can walk away hopefully having a better understanding of what it is and how to use it in your clinical practice for assessment and treatment. Also talk about a little bit of how it relates to where MI fits in, because they are separate models. They don't always go together, although we tend to use them together quite often. So being able to understand where that fits in, and begin to think about the foundation of MI, which is the spirit of MI, as a guiding principle to apply across a lot of the clinical work that you might be doing, or the populations that you're working with. So essentially, how can you apply the spirit, which doesn't require a lot of technique, to all of the work that you're doing when it's appropriate based on that individual's stage of change. So let's first start with the stages of change and highlight what you need to know about it and why it's important. So it's called the trans-theoretical stages of change model. It is an EBP, it's an evidence-based model that is extremely helpful at matching a person where they're at with what they need to benefit from treatment. So you think about it as not necessarily a treatment in and of itself, but in an assessment model. So it's something that can be helpful to stratify the population that you're working with, and make a determination of what kind of interaction with them is going to be most beneficial at that point in their care. So another thing I want to highlight, because we often get these things mixed up, is the stages of change model is not part of MI. It can be utilized very effectively with MI, and I'm going to show you where MI fits in, so where it would be recommended to use MI depending on the patient's stage. But they can be used separately. So they were developed separately. They are not integral. So let's focus specifically on the stages of change. I'm not paying attention to the chat. So if anybody has a question, just feel free to unmute yourself and interrupt me. I promise I will stop talking. Or we can get to questions at the end. So the stages of change model, we think about it as an upward spiral. Or think about it like a spiral staircase. So that means that patients don't have to move through each one of these stages necessarily in a completely linear way. So it starts with pre-contemplation, goes to contemplation, preparation, action, maintenance, and then relapse. They don't have to hit every single one of these in order. Sometimes they can skip. So for instance, somebody might come to treatment and they're already in the action stage, and we'll talk about what that means. So they're already actively doing things to change their behavior. And then they have a slip, which might throw them into relapse. Well, they're not gonna then start right at pre-contemplation. They might go right back into action. But so you think about it as patients take all of the strengths and the tools and the things that they've learned before they've even come to treatment, and then all of the strengths and the tools that they learn over the course of treatment, they can sort of move through these stages, kind of skipping what might be needed to be skipped each time they might have a slip or a relapse, and eventually over time those become less frequent and until they stop occurring, right? So then they're able to sort of stay solidly in maintenance for a long period of time, and that's our ultimate goal, is to get people to that maintenance place and have them stay there for the remainder of their life, while they're able to sort of maintain all the gains that they've accessed. So you think about it, this upward spiral, they're always climbing the staircase. They never really go backwards, but they just might turn the corner and whoops, here I am back in contemplation. I might need a little bit of work to move me into preparation, a little bit of work to move me into action. So if you think about it as like that spiral staircase, they don't go backwards, they keep moving forward, but they might just turn the corner and hit one of those other stages. Or they might skip a couple steps and go up to the next corner, depending on their individual course of treatment. So What do you need to look for? So there's a lot of different assessments that are lined up with the stages of change model to help you determine which stage someone's in. But the evidence is pretty clear, which is just if you understand what each stage means, you can use your basic clinical interviewing skills to sort of match it, and you're pretty accurate. So you don't necessarily need a specific assessment to determine. So understanding just the stages themselves is your best tool for being able to identify which stage someone's in by looking at their behaviors, right? So pre-contemplation is a stage that folks are in when they're not considering change in the foreseeable future. It doesn't mean that they're unaware that there's a problem. We know, for instance, a lot of folks come to treatment because of tremendous problems that they're experiencing, or their family or their loved ones or their job, various things have gotten them to treatment, but they don't want to make a change. So they're just not in a place where they're considering it in the foreseeable future. Maybe like, yeah, at some point I'd be willing to do that, but not now, right? So that's pre-contemplation. Contemplation is where they are definitely considering change in the foreseeable future. So the problems might be the same, whether they're in pre-contemplation or contemplation. The consequences might look the same. The diagnosis might look the same. But it's their focus on, am I willing to do something about it? Do I want to do something about it now versus later? Preparation is where they're actually planning on making that change, like in the next week, right? So the next several days, they have a plan. What are you going to do this week on those change behaviors? That's preparation. And then action is where they're implementing meaningful change in the recent past. So that's when they come in and they say, I did X, Y, and Z, right? I actually implemented some sort of change in terms of my behaviors, whether that's taking my medication correctly, whether that's coming to the appointment, whether that's, filling out job applications. It could be various behaviors, but they've made the change in that recent time zone. And then maintenance is being able to maintain whatever that change is for a period of time. So it's not backtracking to old habits. It's showing that they can maintain that new habit for weeks or months or even years. So the stages of change dictates the intervention strategies that should be used. And the evidence is pretty clear that if we match our intervention strategy to the correct stage, we're going to be more effective. And that makes sense, right? We're providing the right treatment at the right time rather than trying to do a one-size-fits-all for everybody, which is usually not successful, especially in the realm of treating substance use disorders, which is one of our more complicated conditions that we work with. So pre-contemplation, because somebody's not considering making change, we are not going to emphasize motivational interviewing techniques. They're not in a place where they have ambivalence, which we're going to talk about here in a second. There isn't a part of them that is thinking about making a change. They might be aware of the consequences of their current actions, but they're not in a place where they want to really do anything about it. So all you're focusing on in pre-contemplation is developing that relationship and that alliance and starting to introduce points of ambivalence. So using techniques like a pros and cons list, balance, where you're having a thorough discussion with them about, okay, tell me what you're getting out of your use. What is it doing for you? And tell me what it's not doing for you. Tell me the things that it's causing problems with, right? So you're helping them to start to like weigh that and see, oh yeah, there are some things that I really would actually like to do something about. That's all you're doing in pre-contemplation. You're introducing space for ambivalence, and you're really working on supporting them, encouraging them, building the connection so that they feel that this is a non-judgmental relationship, that they can begin to cautiously explore change behaviors, which is scary, right? So they need that rapport and that alliance. Contemplation is the stage of change where MI is going to be most effective. And so by the time somebody comes and they said, absolutely, I have two minds. One of me wants to make a change. The other part of me is really scared about doing it or not certain I can do it very well or don't know how to do it. That's when MI is gold. That's when you want to use your MI techniques to really move somebody at that point. And in fact, if we do decisional balances when someone's in contemplation, we start emphasizing or discussing the pros of their use. We pull them back into pre-contemplation. We can actually move them in the wrong direction. So that's why it's really, really important that we assess their stage of change correctly. Preparation, you no longer need MI because they're already bought in. They've already decided and they've jumped on the side of the fence of making the change. Now they just need to do some planning. So this is solution-focused planning. And 9 times out of 10, most folks don't need much help with this. They already know what to do. It's pretty concrete. So preparation is really just being supportive and listening and helping them kind of think through the details or the barriers of whatever their plan is and making sure that it's in like a SMART goal format. And then action is taking the planning into implementation. And so that's where we're focusing on relapse prevention strategies, things that are going to get in the way, like high risk situation planning, using scheduling, that kind of thing that falls into the relapse prevention category. And we're really emphasizing their self-efficacy, that they can do it, that they're showing that they can do it, and that they're just taking steps, so iterations of the change that they want to make. And then maintenance is where we're solidly reinforcing and teaching relapse prevention strategies. Again, really reinforcing their self-efficacy, because by the time somebody gets to contemplation, their motivation to change is there. They want to make the change. What's usually getting in the way is their lack of self-worth, lack of self-confidence, that they don't feel like they're going to be successful. And so that's what we're combating. It's not the motivation, but by the time they've gotten to contemplation, they're ready to do it. We just want to help them move through. You can do it. That's the thing that we're focusing on. So these next slides, which you guys are going to get, so I'm not going to go into a ton of detail, highlight some specifics. So when a person's in pre-contemplation, again, really we're just focusing on bringing the problem into awareness, really thinking through that in our conversations, listening, eliciting, and communicating that we're not going to judge them, we're not going to stigmatize them, we are accepting them for where they are right now. They are autonomous in the choices that they're making, and so that they can choose to continue to do what they're doing. Here's the consequences to that, and here's the pros to that, right? And so you're just sort of weighing that out for them, and always emphasizing the relationship. In contemplation, this is when you're going to pull in your actual MI skills, where you're going to try to move them towards action as soon as you can. So keeping them talking about change, not going into sustained talk or talking about why they should keep doing what they're doing. We're now shifting to why you should be making the change, boosting their awareness of options so that there's more than one way of doing it, increasing the perceived benefit of change, helping to develop discrepancy, right? Reflecting that ambivalence. So one part of you really wants to do it, the other part of you is really scared and doesn't know how to do it. Exploring that, reflecting on their values and how living in a value-directed way is actually in the service of either decreasing their use or taking their medications or doing whatever it is that is in the service of positive change. Addressing any discord that might be showing up. And a quick reframe that's really helpful when someone's in contemplation so that you can avoid the argument that you might get into is avoiding your language by when they're telling you their reasons for not changing. Instead of saying yes, but, and then filling that in with all the reasons why they should change, switching that to a yes, and have you considered X, Y, and Z, right? Yes, you're absolutely struggling right now, and you're also doing this and coming to this appointment, and so you're reinforcing that self-efficacy. That's a really subtle shift, but it makes a big difference for people that are in contemplation. And then also just reviewing past successes, affirming, bringing a lot of optimism, helping them to remember their commitment to change. Then in action, our goal is really just to encourage progress, talk through barriers, and keep them from biting off more than they can really chew sufficiently. So helping break things into SMART goal format so they can be successful. Relapse is a really common occurrence. That's why it is part of the stages of change. It is not a sign of failure. And it's really important that just like how we say talking about suicidal ideation does not cause suicidal ideation, it helps us to assess more accurately and be effective. The same thing's true with relapse. Talking about the potential for relapse does not mean you're going to cause relapse. So it doesn't give permission for relapse or some of the old ways of thinking about it. It actually just helps us to prepare and plan effectively to normalize the fact that this is a chronic illness, that relapse and slips are very common, and that if they happen, there's a plan. So we're trying to avoid them from becoming discouraged. We're trying to avoid them from going back to pre-contemplation. We want to keep them in that action and maintenance zone. And the way we do that is making sure that we've prepared for relapse. And that's exactly what relapse prevention is, and why it's so helpful to be doing that once you move into the action phase. So let's talk about the spirit of MI and why that's important and where this fits into using the stage of change model. So I like this quote, which actually comes from 1660 by Blaise Pascal, which says, "People are generally better persuaded by the reasons which they themselves have discovered than by those which have come to the mind of others." And this was true then and is true now, and especially true in regards to why we change. So if it's not meaningful to them and it's not coming from their rationale, it's going to be less effective. And so the nice thing about MI is that it is a way of being with people. It is an effective method of talking to people about change. It is not a series of techniques. So it really much embraces utilizing a collaborative approach, a person-centered approach. It's not do whatever you want and I'm going to support you. It is a guiding approach. So we're always directing towards health and positive change, but it's strengthening their own motivation. It's what comes within, which is a different viewpoint than the standard medical approach, which is sort of like, I need to tell them what to do, and then if they do it, they'll be healthy. So with MI, what we're really focusing on is figuring out why they want to do what they want to do, and using a way of talking about change and ambivalence to help them do that. So it's different in that it's collaborative, person-centered. It's not a series of techniques. It works with the patient, not at the patient. And it's used to encourage a whole host of healthy behaviors. So we find that even if somebody doesn't want to move on their use behavior, but they are willing to talk about and make some changes in their relationships, in their work life, in volunteering, in their community involvement, in how they come to appointments and how they take their medication, all of those things are going to produce changes in their use behavior down the road in the service of global health. So it can be used to talk about any kind of change and still be in the service of providing good substance use treatment. I'm not going to go through this. I'm just going to say it's extremely evidence-based. There have been thousands of studies on MI. It is very effective, particularly for people that are in that contemplation zone. So where I want to end up in this conversation is highlighting what you can use today and moving forward, whether or not you've had MI training. So that is using the spirit of MI. And the spirit is really the foundation of this approach. And where it starts is by accepting and honoring ambivalence, recognizing that we need it in order to help people move forward. So it's not a bad thing. Really, it just means feeling two ways about something. It is not a lack of motivation. So when we say, well, we just need to wait till they're more motivated and then we can do something, that's really on us. That's not the correct way of really thinking about it. We can think that when somebody does have a conflict, hey, that's great. I can work with that. I can actually highlight that ambivalence and recognize they're walking on that fence and help them to figure out which side of the fence they really want to fall on. And ideally, it's the one for health. So it's a normal part of a change process, and it has to be there for any habit to adjust. So what we want to avoid when we're using the spirit is what's called the communication trap. So what happens instinctually, and anybody who has kids has probably run into this, when you start having a conversation with someone, when you tell them what to do, or you start arguing why they should, you say you should, you have to, you need to, or because I said so, what's going to happen is they're going to automatically start arguing the opposition. It's just how our brains work. And so knowing that, your goal when you're working with someone with the spirit of MI is to not fall into that trap, is to not start arguing why they should, they need to, or have to, because all you're going to get from them is what's called sustained talk, which is arguing why they should stay the way they are and not make changes. So we want to get them on the other side of that. So what we are doing is maybe defending the status quo so that they can start to support change. And that's why it's so important that we only use this when somebody is in contemplation, because that's when they're going to be ready to hear it. We also want to avoid what's called the righting reflex, which is our natural inclination to help someone change for the better. Now, it's normal because we're helpers. We want them to do better. But the second we start saying you should, you need to, you have to, they're going to start arguing the other side. So we have to challenge those beliefs. When we're using the spirit of I, we have to challenge this belief that they don't see it, they don't know that it's a problem, they don't know how to make a change, or they just don't care, right? They're just so stuck they don't care. And that's not true. If they really are in contemplation, it's not our job to give them insight, knowledge, or skills. It's our job to avoid this collision. It's our job to work with them, right, instead of at them, or else this is what it's going to feel like. And all of us have been in the situation where we're completely in the right. We know exactly what they need to be doing. It's that righting reflex. We're telling them how they need to do it and why they should do it. And it's not getting through. They're pushing against us with equal force. So that is not using the spirit of MI. So what tends to happen is patients might make a change briefly because they want to be a good patient, they want to satisfy us or their family or whoever, but it's not going to last. They might listen politely and then just go ahead and do whatever they're going to do. They might protest and push really hard, and we've gotten those patients before, but at the end of the day, nobody benefits. And what we tend to do as helping providers is we blame them and we say they're just not motivated, they're just not ready. And it could be two things. One is we didn't assess them correctly, so we were trying to use the spirit of MI when it wasn't the right match, or two, we fell into that communication trap and we're using the righting reflex. So what we want to start doing instead is using what's called a rule, which is resist the righting reflex, make sure that we are not coming at them with what they should have to need to do, that we're really seeking to understand their motivations, because remember, if we can highlight their values and what's important to them, why they want to make the change, they're naturally going to figure out how to do it. So we also need to listen to our patients to be able to understand those motivations. And then we need to seek ways that we can empower, encourage, and support that self-efficacy. Because remember, the number one thing that keeps people from changing is their sense that they can't do it. It's not that they don't want to do it. It's that they believe that they can't. And so that's on us to really be working to push against, right? That you can. Let's look at all these ways you've been successful in X, Y, and Z. Let's talk about what your fears are about making this change that's so important to you. So remember that in terms of motivational interviewing, at whatever level you're using it, the spirit is the foundation. So you can apply the spirit to almost any setting or patient where MI would be called for, regardless of if you know these other things that are set on top of the foundation. So within the spirit, our main emphasis are these three things: acceptance, collaboration, and evocation. And so it's really nice to be able to use it because it feels great for us as a provider to just focus on my job is to help reflect absolute worth, to provide positive regard in the absence of judgment, to always be emphasizing respect and trust. When people experience this, they naturally feel free to change, regardless of knowledge, skills, all that stuff. To make sure that we are listening so that we can reflect accurate empathy, so that we can really say, I get why these motivations are yours. I get why this is important to you. And then providing them what's called autonomy support. So acknowledging that they can make these decisions, even if they're actively using, and affirming that they do have the strengths and the skills to be able to do it. So if you kind of look at it, historically, the traditional medical model, we tell them how they must do it, versus collaborating with them. And then with collaboration, what we're doing is really helping to use their own motivations and supporting that. So rather than saying that they need to or they have to, developing that partnership that really honors their own expertise and their own perspective. And then with evocation, what we're doing is just bringing forth what those motivations are. So they don't have to be ready. They just need to hear reflected, right? What comes to their own mind. And then that will strengthen their reasons to change. So those are those perspectives. So really, treatment without the MI spirit feels like wrestling, feels like headbutting, versus treatment when using the ACE, the spirit of MI. And it moves fluidly, and it feels better for both parties. And so that is really what I'm hoping to leave you with today. So I know we're right at 1, but I'm happy to stick around for a minute or two if people have questions based on that lecture.